If ApoB measurement in the blood exceeds a certain level, there are more ApoB particles circulating than the liver is clearing. And as that number goes up and up and up, the particles are obviously not being cleared by the liver. So where do they go? We have miles and miles of endothelium on our arteries. So they just pick the nearest artery and they crash it. And the ApoB particle carrying cholesterol, step one of atherogenesis is it passes through the endothelial lining, which is a one-cell lining of every artery in our body. And now it's in the artery wall.
Welcome to the Proof Podcast, a space for science-based conversation exploring the health and longevity benefits that come with mastering nutrition, physical exercise, mindfulness, recovery, sleep, and alignment. Facts, nuance, and trustworthy recommendations, minus the hyperbole. In today's episode, I sit down with Dr. Thomas Dayspring, arguably one of a handful of leading experts in the world when it comes to understanding the role that lipids play in atherosclerotic cardiovascular disease. Tom is a fellow of both the American College of Physicians and the National Lipid Association, and is certified in internal medicine and clinical lipidology. His resume is far too long to read, but just know you're in great hands. From writing textbooks on lipids, to publishing peer-reviewed papers, to being the associate editor of the Journal of Clinical Lipidology, and illustrating some of the finest lipid images I've seen, Tom is certainly at the top of his field. This conversation is the first part of a mini-series that we're doing. In this episode, we focus on the lipid transport system, how our body transports fats and cholesterol, and what goes wrong when we develop atherosclerosis, fatty plaque building up inside the artery wall. It goes without saying that this is a very complex area of science, but it is really important to understand things at some level of detail, or else it's very easy to be confused when presented with misinformation on social media. The details here matter, and my hope is that although it is complex, this episode gives you a greater appreciation for how this system works, what various terms mean, and what causes things to go wrong that ultimately ends up resulting in fatty plaque building up in our arteries, predisposing us to a heart attack or stroke. Stick with it, even if things don't land the first time. And if you are visually inclined, be sure to watch this on YouTube, where my team and I have worked with Tom to provide important illustrations that help explain some of the new concepts as we move through the conversation. And keep in mind, we will double back and re-emphasize some of these new concepts in the upcoming episodes, where we delve into assessing your risk of atherosclerotic cardiovascular disease and interventions that can help you lower risk. Atherosclerotic cardiovascular disease is the number one cause of death globally. Statistically speaking, the most likely reason our life will be cut short. If we really care about our health span and longevity, we have to study this. And as Tom says, take control of our health and optimize our lipids as early in life as possible. With that, here's my conversation with Dr. Thomas Dayspring. He's certainly an inspiration to me and to many others who are passionate about preventative cardiology. So it was a real pleasure to have this time with him and to be able to share it with you. Please enjoy. Tom Dayspring, welcome to the show. It's a pleasure to be doing this.
And likewise.
Firstly, I have to say thank you for all of the work that you do. Your communication through published papers, chapters in books, the illustrations particularly, the tweets that you do, and the podcasts and everything that you do with such high energy. It's helped me personally try and make sense of what is a very complex system in our body that transports fats and cholesterol, and where these things can go wrong that lead to disease. So thank you for all that you do. I really appreciate it.
No, it's been a great pleasure. You know, I'm a self-taught lipidologist and spent a long time learning it. And thank God, as I learned it, I somehow picked up the ability to explain it to others. And probably my real claim to fame, as you mentioned, I'm a pretty good illustrator with PowerPoint. And there's nothing that's a better teacher than illustrations rather than the written word or spoken word.
Mm-hmm. Totally agree. And I guess I should point out that we'll try and include a number of those illustrations where it makes sense. So if you're listening to this on audio, be aware there will also be a video format on YouTube. So if you are someone that is a little bit more of a visual learner, then you can hop over and make the most of that as well. Tom, I have kind of three main goals for this part of our conversation. And they are to explain the system that the body uses to transport fats and cholesterol, so people are aware of what this system is. And then to kind of explain where this system can go awry and how that can increase the risk of atherosclerosis, the buildup of cholesterol in the artery wall. And the third goal is to have fun. So that's the challenge that I'm throwing out for us today. Does that sound like a realistic set of goals?
No, it sure does. And if you do these type of teachings or interviews and they're not fun, nobody's going to listen or watch. So we'll definitely,
right.
You see, I'm smiling already.
Okay, well, we'll try our best there. I haven't shared this with you, and you may not be aware of this, but the reason that I'm really passionate about this topic and sort of helping people understand the things that they can do to prevent cardiovascular disease goes back actually, Tom, to when I was 15 years old. And I grew up in Melbourne in Australia. And my parents were divorced when I was about 10 or so, and I'd spend every second weekend with my dad. And so these were times that I really cherished. And on one weekend, we were out driving in the Yarra Valley. This is a wine district known for Chardonnay and Pinot Noir. It wasn't so much about the wine, it was just spending time together, right? And we would go around and hop from winery to winery. And on this one particular day, it was just my dad and I. My brother would often come, but he wasn't there. We were driving back home, and it was a Sunday because I remember I had school the next day. And my dad started to get some pain in his chest and was sort of rubbing his chest and his shoulder. And I inquired and asked if he was okay. I could tell that he was uncomfortable. And he kind of assured me, no, it's okay. He thought maybe it was indigestion or heartburn or something, and sort of downplayed it, perhaps to kind of protect me and to not get me kind of worried about what he was experiencing. And so we got home and we cooked dinner, and by this time he said, he felt a bit better. And so we had dinner and I went off to bed. And a couple hours later, Tom, I woke to some noise in the kitchen, and I thought, well, I better go and check and see how my dad's doing. And I went out, and by this stage, he could no longer deny what was happening. It was very evident. He was out of breath. He was kind of kneeling over, and he had called 000, which is the 911 number in Australia. And they asked him if there was anyone else there that could speak to them to kind of describe the situation. And so that was me. And very quickly they said, based on your location, because we were quite remote, we were about an hour drive to the nearest main hospital. They said, we're going to send a helicopter. And they sent a helicopter. It came before I knew it. Everything was happening, at rapid pace. And they came in and scooped my dad up and put him onto a stretcher and hooked him up to oxygen and all of the different, checking his pulse and whatnot. And before I knew it, he was in the helicopter and taken to the hospital. And I was put into the ambulance and went by road to meet him at the hospital. And so that was a long drive, and got to the hospital, and they saved his life. They gave him antithrombotic medication and stabilized him. And he found out that he had very high cholesterol, he had high blood pressure, and since then has been on sort of antihypertensives and a statin and ezetimibe, some of these drugs that might come up during our conversation. And he's still going strong today, 20 plus years later. So great outcome. But I guess that moment kind of, for me, I saw firsthand what this disease can do. And I kind of realized that my dad was very lucky, and not everyone in that scenario is that lucky. So very thankful for modern medicine. But now I guess I have this deep passion for better understanding the disease and doing my best to speak to people like you to help communicate the science to people so that they can prevent it, make changes in their life, and get on top of a disease, because it really feels like we have a lot of information and we could be doing a much better job at preventing this. Is that how you feel?
Oh, I sure do. And you had a happy ending to that story, but imagine if your dad would have passed when you were out in the outback there, you being alone with a dead man. I don't know how that would have affected the rest of your life mentally or so. But listen, it's a similar scenario. Why did I even decided to pick up lipids? Look, I graduated med school in 72. I call it the dark ages. But it was a cool time because they had just invented the concept of a coronary care unit, and coronary bypass and coronary angiography was showed up at that time. So it was like the real exciting place to be. But at that time, and there was so much heart disease, acute heart disease, cases like your father, acute coronary syndromes, that when they showed up in the hospital in 1972, we gave them a bed, we gave them oxygen, and that was it. There was nothing we could do. We might treat an arrhythmia or something like that. And so many of them just died, half of them by the next morning. So it was soon in my life that I realized, God, if I want to have a happier life as an internist, I have to learn everything I possibly can about atherosclerotic heart disease. Blood pressure pills came along first. I jumped on that bandwagon. But it's the appearance of the science of lipidology that really made massive inroads in slaying this disease. And I did jump on the bandwagon in a very early stage. So just the same thing. It's no fun witnessing people having heart attacks. And especially when you're a physician, I really can't do much.
Mm. How do you think we're going today with all of the information that we have and what you understand about lipids and atherosclerosis and preventing this disease? How are we going?
We're not going anywhere near as fast as we should, that's for sure, because we absolutely have the facts and realization now that if early in people's lives, we can periodically evaluate them with a whole variety of diagnostic tools that we now have readily available, we can, at a young age, ascertain, there is going to be atherosclerotic whatever in this man or this woman's future. But I have identified what we know to be very treatable risk factors. And the sooner in life you recognize that risk and you treat it appropriately, I think you can eliminate atherosclerotic disease as a morbidity and certainly as a mortality. I find it so sad. Your dad could have died, but every day we pick up the paper or put on the TV and some famous person croaked of a heart attack. And I deep down know that was totally preventable if a decade or two ago somebody would have done a proper evaluation. So the mission is to get everybody accept that common sense realization, do these tests, and then just don't say, hey, these tests are abnormal, but they're not that bad. I'm not worried about it. That's malpractice. You got to start aggressively treating and we have many modes of therapeutics. It doesn't mean everybody goes on 3 drugs when they're 18 years old, but we have ways of just halting atherogenesis. But it's slow to catch on. As tragic as that seems, I believe globally it's the number one cause of morbidity and mortality, for goodness sakes. So I don't know why more people aren't looking for the signs, the biomarker signs, the imaging signs of this disease and saying, sir, ma'am, you have a problem. Here's the good news. For almost all of the people, I can really reduce the outcomes that are likely coming your way.
Yeah, well, I'm hoping through this conversation and the next couple that we have, we can shed some light on assessing risk and some of the key things to look at a high level here. So we're talking about atherosclerosis, which is the buildup of this fatty plaque in the artery wall. Is that the most common cause of cardiovascular disease?
Yeah, the word cardiovascular disease is a humongous category. There's so many afflictions that can affect the heart and the blood vessels. But the most frequent one that we see all the time, the one that is putting people in the CCU or, God forbid, in the graveyard, the bypass unit, is atherosclerotic cardiovascular disease. And notice I didn't say coronary artery disease, because atherosclerosis can occur in several of the arteries that carry blood in our body, our neck, our brain, our abdominal organs, our peripheral legs and extremities. All of those can build up these plaques that lead to all sorts of bad things. It doesn't include cardiomyopathies and arrhythmias not caused by ischemic disease or congenital diseases. There's so many immense field of cardiology and cardiological diseases. Tonight, we're talking about the most common one.
So you mentioned before that there are a number of risk factors that have been established. So at a high level, when it comes to atherosclerosis, if we're thinking about what is increasing our risk, what are the sort of the top handful of risk factors that would contribute to the development of that fatty plaque buildup?
And we should say there's really two things we're looking at. One are risk factors. They're pretty much, if they're abnormal, they're causal of the disease. And then there's a bunch of things we call risk marker that would add to whatever risks that the risk factors outline, but they're not treatable per se. Risk factors, because they're causal, if there is a therapy, they're treatable. So to do the best risk assessment, we use both risk factors, and there are numerous risk markers. And you put them together, and at least in their blood tests, their biomarkers, we have a pretty good idea what we're dealing with. We have other tools to further elucidate the extent of is there atherosclerotic disease present or not. But risk factors and then risk markers are the everyday tools, readily available throughout the world, for the most part, rather cheap.
Right. And so some of these are things like high blood pressure, elevated LDL cholesterol.
Smoking probably leads the list. So if you smoke, good luck to you. You're subjecting your body likely to a lot of things. So we take that out of the picture. We're not going to discuss that tonight. The others, high blood pressure and lipid disturbances, or 2 and 3 or 3 and 2, however what you want to list them. And if either of those have abnormalities there with the tests we use to make that hypertension or lipid diagnosis, they require serious treatment. Look, there's things we can't do anything about. Male gender is a bigger risk factor until later in life. Then females take over, but men do get heart attacks younger for the most part than women. So things like that. Age is a major risk factor. I don't know what to do about that.
Well, there are some people that are working on that, I believe.
Yeah, no, my good buddy Peter Adi is sure trying.
Yeah,
but
exactly. Yeah. Okay. Well, the focus of this is on lipids, our conversation anyway, which, as you mentioned, can be a major risk factor when there are disturbances. I think for people to appreciate the disturbances, first we have to understand the system. We have to understand what are lipids, how our body transports these, and what the purpose of that system is. So perhaps we can start there.
Yeah, you absolutely have to start there, because the lipids, I mean, how many times have I said that in my life? But many of the average layman may not even know what a lipid is if he was asked on the street, hey, what's a lipid? So a lipid is basically an organic molecule. Organic molecule means it's carbon and hydrogen atoms that are all stuck together in various configurations. But it's an organic molecule that is not soluble in water. So, and the simplest thing is, hey, take olive oil, take a glass of water, pour it together, and the olive oil doesn't freely mix. My joke is, hey, if I did Dewar's in water, Scotch in water, they're very miscible. There's no droplets in that glass. So lipids are not soluble. And this presents, so any molecule that is not soluble in water is under the lipid classification. Now, it's a family of a lot of different molecules, and the ones we're going to spend most of the time on in our podcast are going to be sterols, and the most common sterol is cholesterol, and then the fatty acids. And the fatty acids, usually are part of a lipid called phospholipids or triacylglycerol, triglycerides. So those are mostly the lipids that we're going to be talking about. How in the world are they related to cardiovascular risk or atherogenesis, the buildup of plaque? So that's what lipids are. And with that simple introduction, here's the whole darn dilemma. There's no human life without lipids. We need fatty acids for energy. We absolutely need cholesterol for our cell membranes. They provide integrity and the ability for membranes to signal. No cholesterol, no cell membranes, no cells, no podcast tonight if you and I weren't constructed of cells. So cholesterol also is a precursor to several hormones that are necessary for life. And cholesterol is the substance from which the liver makes bile acids, and if it didn't make them, we couldn't absorb anything, and we'd be in a bad way too. So cholesterol is so crucial that evolution knew we have to give every cell in the body the ability to manufacture, synthesize cholesterol. And we also have to maybe develop a lipid transportation system that could track lipids, the energy-carrying lipids like triglycerides, and even cholesterol if needed, to a tissue that says, hey, I need cholesterol. It has to go from where cholesterol is being produced to somebody who wants to use it. And that is the problem, because plasma is our vehicle, how we transport things in the human body. And plasma is pretty much a total aqueous water solution. So if the liver or any other tissue is making lipids, it just can't dump them in the plasma, no more than you can pour olive oil in that glass of water. So evolution, which solves a lot of problems, said way early, whenever it started, in whatever species it started, we have to develop a lipid transportation system for humans so lipids can go here, there, and everywhere, or perhaps brought back to an organ that can get rid of excess lipids that are not needed. So all that was necessary was the chemistry realization that if you stick lipids on a protein, proteins for the most part are water soluble. If I have a collection of lipids bound to a protein, that is a lipid transportation vehicle. And obviously you would call that a lipoprotein because it consists of lipids and a protein or more than one protein. So our body was given the ability to produce lipid-carrying molecules called a lipoprotein. And two organs were blessed with the ability to make lipoproteins. Our intestine, because as you can imagine, we're absorbing lipids from the gut lumen and into the intestine. But for the intestine to send those lipids to where they might be needed, it has to wrap them with a protein and then secrete that protein into the systemic circulation. So the intestine can make a lipoprotein. And the only other organ that can make a lipoprotein is basically our master chemical control system called the liver, which makes everything we pretty much need in the body. So if the liver can take collections of lipids, wrap it with a protein, and secrete it into the plasma, so here all of a sudden we've got these spherical large particles carrying various lipid components, and they can go and bring lipids to whatever cell might need them. And if that cell needs a lipid, it would upregulate a receptor that internalizes the lipoprotein with its content. But equally important is if a cell had too much lipids, and look, too many fatty acids, inflammation, if it's the liver, fatty liver, too much cholesterol in any cell in your body will crystallize and kill that cell. So once a cell has above a very slight threshold of cellular cholesterol, it has to get rid of it. Now, that cell just can't pump it out into the blood. No, it has to pump it out into a lipid-carrying vehicle, and that would be a lipoprotein. So cells that have excess lipids can say, hey, Mr. Lipoprotein, please take this from me, and please take it to somewhere that can use it or eliminate it from the body. So lipids, cholesterol and triglycerides that I have spoken about, are trafficked within these little circulating fat, protein-enwrapped fat balls called lipoproteins. But lipoproteins take lipids in a forward direction from the intestine or liver to various cells, or in a reverse direction from cells back to the liver and say, you deal with it. And the liver is very skilled at handling excess lipids, eliminating them or changing them into other things. There could be some side trips if a lipoprotein is carrying triglycerides, which is basically a form of energy because there's 3 fatty acids on it, which if oxidized will create ATP. That lipoprotein could stop at a triglyceride storage organ called adipocytes. Our fat cells would say, oh, I'm happy to take some of the triglycerides and I'll keep them here until the body needs them again, and then I'll release them. And a lipoprotein could bring, especially cholesterol, not triglycerides, to those steroidogenic organs I talked about, cholesterol being a precursor to several hormones. So the adrenal cortex sometimes needs cholesterol from a lipoprotein. Our gonads sometimes needs cholesterol from a lipoprotein to synthesize the various things they're doing. So you could say lipoproteins, it's the lipid transportation system, and there could be several pit stops along the way. As we get into this, what's fun is what makes a lipoprotein go there, 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 and it's all regulated by a variety of enzymes and receptors. It's such a fascinating little system we have, but it's basically the lipid transportation system. And my famous words, I've said it a million times, lipids go nowhere in the human body unless a lipoprotein brings them there. Of course, unless the cell is synthesizing its own lipids, but and that happens pretty much with cholesterol, but not so much. Only a few organs can synthesize triglycerides. Trigs have to be delivered to the organs that need energy.
Okay. So these lipoproteins are essentially transport vehicles for the triglycerides and for the cholesterol, which are unable to transport to move through circulation unless they're attached to this protein. That's what makes them soluble.
One more little caveat there. These particles, I've talked about the protein, I've talked about triglycerides and cholesterol, but these are fat balls, and there is a 1 molecule layer surface on every one of these particles. And that's where this class of lipids I've mentioned comes in, phospholipids. Now, phospholipids are as crucial as is cholesterol for the construction of cell membranes in the body. Most of the phospholipids are pretty much made in the intestine or the liver. So in the liver or the intestine, when it makes these particles, it wraps them with phospholipids. And so another thing these lipoproteins can deliver is phospholipids to where they are needed. We never talk about that in lipidology because we measure triglycerides on everybody. We measure various cholesterol metrics on everybody. Nobody measures phospholipids, but they're a super integral part of this whole lipid transportation story. More on them later.
Yeah, let's come back to that. I'm going to put a pin in that. We'll make sure we come back to it. You mentioned that lipoproteins are synthesized in 2 locations. So in the intestine and then also by the liver. So perhaps we double click on that and we start to think about what are the different types of lipoproteins that the body is producing.
Yes. And there's always a caveat in lipidology. So yes, the lipoproteins that are so crucial that are synthesized in the intestine or the liver are one class of lipoproteins. But there is another class of lipoproteins that are not made in liver cells, are not made in intestinal cells. They self-create themselves in the plasma. And those will be our high-density lipoproteins, our HDLs. And what this makes, how you distinguish them from all the other lipoproteins, chylomicrons coming out of the intestine, very low density lipoproteins coming out of the liver, the byproduct of a VLDL, which would be an intermediate density lipoprotein, or our friend Mr. LDL, low density lipoprotein, which can be directly made and synthesized out of the liver, or could be the byproduct of VLDL and IDL catabolism. As they lose their lipids, they get smaller, 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 and you go from very low density to intermediate to low density. So, but the VLDLs, IDLs, LDLs, and the chylomicrons, we differentiate them from the HDL particles because of the protein that enwraps these particles, giving structure and stability. Chylos, VLDLs, IDLs, and LDLs have one major monster integrity structural protein enwrapping them, and it's called apolipoprotein B, APO for B for short. And thank goodness there is just one ApoB per ApoB particle, So that lends itself to being a fantastic laboratory measurement. If we just measure ApoB concentration in the blood, we are actually counting all of the ApoB particles. For short, we call them the beta lipoproteins. So it's a big family, chilos, VLDLs, IDLs, and LDLs. Whereas the ApoA1 family, ApoA1 is the structural protein of our HDL particles. Both the liver and intestine manufacture ApoA1, the protein, but they secrete it. And then you have free ApoA1 floating. It's a protein. It can circulate in the plasma, but it virtually instantly attaches to cells that are willing to give up cholesterol. And the little ApoA1 starts what we call lipidating with cholesterol molecules. And before you know it, you have more mature big HDL particles self-constructed in the plasma, whereas the ApoB particles are made in those two tissues and secreted.
You mentioned a few things there I want to unpack. So we eat a meal and that contains some fats, and let's say there's some dietary cholesterol in there as well. That comes in down the esophagus, it goes into the stomach, it comes into the small intestine, and our body says, well, let's absorb some of those fats. That's an energy store. That's great, and it may pull in some of that dietary cholesterol, I believe, along with some other cholesterol that's in the intestine that could have come from the liver. I'll get you to unpack this, but I'm just going to try and summarize. The in the intestine there, the fats and the cholesterol get packaged into these lipoproteins at that stage called chylomicrons.
When you have whatever collection of lipids in your intestine because you swallowed them, and there could be cholesterol, there's almost certainly fatty acids. You may have swallowed them as triglycerides, but the intestine hydrolyzes them to fatty acids. So once these lipids are coming out of your stomach, the duodenum is the first part of the small intestine, but there's a duct that empties into the duodenum, and the pancreatic duct secretes all these enzymes that'll dissolve the various lipids. Even the cholesterol we eat, most of it is an esterified form of cholesterol ester, which is too big to be absorbed. It has to be deesterified by pancreatic enzymes. So once those lipases from the pancreas, and we have a whole bunch of absorbable lipids, fatty acids, cholesterol, phospholipids, there may be some phytosterols because you ate plants. They have to be brought to what we call the brush border of the small intestine. That's a bunch of villi that stick out, so you can imagine the surface area that gives. But how do the lipids find their way to those microvilli of the brush border? There's actually an intestinal lipid transportation vehicle, and thank God our liver happily secreted bile acids down the bile duct into the intestine, comes out in the duodenum, and bile acids round up the lipids. And when you have bile acids surrounding fatty acids, cholesterol, phospholipids, phytosterols, they're called biliary micelles. It's basically an intestinal lipoprotein, but there's no protein involved with it because the protein would be catabolized in the intestine to amino acids. So the biliary micelles, which are lipid-carrying packages, they go into the brush border of the small intestine. And on that surface area, we have a bunch of receptors, distinct receptors. There are receptors that recognize the fatty acids and pull they're called fatty acid transport proteins. They pull fatty acids into the enterocyte, which is the intestinal cell. But there are also sterol recognizing receptors. The major one is called the Niemann-Pick C1-like 1, NPC1L1. It recognizes any sterols that are in that biliary micelle, and it pulls them into your intestine. So step one of absorption is, hey, fatty acids found their way into the enterocytes, cholesterol, maybe some phytosterols got in here, phospholipids, partially hydrolyzed, they got in too. So now it's the job of the intestine to take all these primitive organic lipid molecules. The fatty acids get resynthesized into triglycerides. Cholesterol, most of it gets reesterified to cholesterol ester. The phospholipids pick up one other fatty acid. So a phospholipid with one fatty acid called a lysophospholipid, but most phospholipids need two fatty acid legs. So it acquires one. Now, all of a sudden, the enterocyte has a pool of phospholipids, triglycerides, and cholesterol ester. Some of the cholesterol does not get esterified. That's called free or unesterified cholesterol. So what does the intestine do with this new glob of lipids it's got? It doesn't want it. You can't keep the lipids because too much lipids cause injury to cells. So then they do what you hinted at. The enterocyte says, oh, here's the ApoB protein I made. I'm going to take all those lipids, stick them on ApoB, and I just made a chylomicron. And the intestine releases the chylomicron not into the bloodstream, but into our lymphatic system. The lymphatic circulatory system, nobody thinks about it, but it's a major transporter of so many things. So the chylomicrons, which are gigantic, by far our biggest lipoprotein, go up the lymphatic circulation, which ultimately enters into the blood vessels in the neck, the thoracic duct it's called. And then all of a sudden, the big chylomicrons are in the bloodstream. Then the chylomicron can go wherever it wants to go to deliver its lipid load. And by far, the primary lipid load of the chylomicron is triglycerides, because we just ate all those fats. Now the chylomicron knows exactly who wants fats for energy. And it's people like you who use your muscles. Muscles need energy. So the first pit stop of the chylomicron is it goes to muscular beds. Now, if you want your heart to keep pumping, that's a muscular bed too. So chylomicrons are a major supplier of energy in the form of triglycerides to skeletal muscles, cardiac muscle, and any other muscle in our body. Smooth muscle cells need energy too. And how does the chylomicron know to stop, like in your muscular beds or in your myocardial beds? Easy, because those tissues, when they need energy, triglycerides, they express triglyceride dissolving enzymes. The major one is called lipoprotein lipase. So here comes this big fat chylomicron. It pulls into your deltoid muscle. You're going to work out. The deltoid muscle needs energy. It will express copious amounts of lipoprotein lipase. There's a protein on the chylomicron that is a ligand for lipoprotein lipase. And the triglycerides get hydrolyzed. That means the fatty acids break away from their glycerol backbone. The chylomicron releases those fatty acids, and the deltoid muscle says, thank you. And they are just pulled right into the deltoid muscle or any other muscle in your body, and they're happy. Now they can start beta oxidation of that fatty acid and create ATP. But you can imagine this. If a chylomicron is supplying copious amounts of triglycerides, and it's by far the biggest triglyceride carrier, sooner or later it's going to lose its triglycerides. And what will happen to a big balloon full of triglycerides when you start like taking the air out of a balloon? It shrinks. The balloon would shrivel, but the chylomicron starts to crumble. Its diameter decreases. And when it does, what has to be released? Whatever's on the surface of the chylomicron. Phospholipids. So phospholipids break off from the chylomicrons as they're undergoing what we call lipolysis, hydrolyzing their triglycerides, becoming a smaller chylomicron. And because it's smaller, we call it a remnant chylomicron. What did the muscle not take out of the chylomicron? Cholesterol. Muscle, if it needs cholesterol, it'll de novo make it through synthesis. It doesn't need a delivery of cholesterol. So the chylomicron loses trigs, loses surface phospholipids, but it loses no cholesterol. And that's why the cholesterol remnants are basically cholesterol-rich chylomicron particles. They've lost much of their triglycerides. Now, the good news is when the particle shrinks, there's another protein on its surface called ApoE, several copies of it. So, and once as a particle shrink, ApoE assumes sort of a different conformation. ApoE happens to be a major ligand for the two receptors in the liver that clear ApoB particles. It's called the LDL receptor-related protein, LRP, which ApoE is what it recognizes, and the LDL receptor recognizes ApoE. So chylomicrons, their half-life is in minutes. Their plasma residence time is 2 hours because our body is just so efficient at hydrolyzing the energy that the tissues need. It disappears. Once it shrinks, ApoE pops up, boom, the liver grabs it and it's cleared. That's why it has a very short plasma residence, but it successfully did what it was supposed to do, bring energy to the muscles. So it's just a fascinating story on how quickly it comes and goes. And this is why if you get a blood test and you want to measure chylomicrons, it has to be a postprandial blood test. Because if you're fasting, the chylomicrons are gone in a couple of hours. So if you fasted for 12 hours, unless you have a bizarre lipid disorder, there will be no chylomicrons in your blood. So when you do a fasting triglyceride, and of course there will be triglycerides in your fasting specimen, they're not from chylomicrons. So I don't have to give you the whole story again, but what is a VLDL produced by the liver? It's basically a smaller chylomicron, but it's a triglyceride phospholipid delivering vehicle. So the VLDL goes to those same damn muscles after the liver secretes it. It undergoes the same hydrolysis with the same enzyme, and the VLDLs deliver triglycerides. They deliver no cholesterol, and once they shrink, they either become an IDL or the liver rapidly clears the VLDL remnants. So the half-life of a VLDL is a couple of hours. Its plasma residence time is 6 hours, 8 hours. So that's the delivery of energy. But a wonderful part of that story is when the VLDLs and the chylomicrons are shrinking, undergoing lipolysis, what are they shedding? Their surface phospholipids. And where do they go? They either can jump into next to the contiguous cell that the particle is butted against, because cells need phospholipids. But most of those phospholipids are grabbed by another protein that floats in our blood. It's a phospholipid scavenger protein called phospholipid transfer protein. So what does this protein that now gathers several molecules of phospholipids do with them? Now we're going to introduce our little baby friends, HDL particles. I told you the liver intestine secreted ApoA1. It's going to cells because it accepts cholesterol. It's being effluxed out of any cell that doesn't want cholesterol. But if ApoA1 has now gathering cholesterol molecules, how can it mature into a big HDL particle? What does it need on its surface? Phospholipids. So the phospholipids that were shed by chylos and VLDLs, grabbed by phospholipid transfer protein, are raced to the maturing little baby HDL, which allows the HDL to grow and become a big, mature, very cholesterol-laden HDL particle. What you should be gathering by this is, wow, our lipoproteins, yes, they're a cool lipid transportation system, but they work hand in hand to help each other build up, empty, and so they're all related. You can't change one without changing the other. And that sometimes will show up in the metrics we measure. So that's the delivery of the triglycerides. The cholesterol that was in any VLDL particles or chylos, once they're depleted of their triglycerides, is rapidly returned to the liver. Their VLDLs and chylomicrons do not deliver cholesterol molecules to any cell. But I did say some of the VLDLs, not chylos, VLDLs, when they lose trigs before the liver, or as the liver is clearing them, some of them don't get cleared. They become intermediate density lipoproteins. It's basically a smaller VLDL remnant. And there's a little bit of trigs in them. Still, this is a lot of cholesterol, the same amount that was in the VLDL. And the IDL's half-life is like an hour. Doesn't linger at all. Why? Because the LDL receptor in the liver is they grab IDLs because the ligand for an LDL receptor is the ApoB that's on the IDL and the ApoE, which is still on an IDL. So they have no plasma residence time. As an IDL is being cleared at the liver has a surface enzyme called hepatic lipase. And it grabs some of those IDLs that the receptors try and internalize, but it causes further lipolysis. So the IDL shrinks. It's not internalized. It becomes what? A smaller IDL, a low-density lipoprotein. Now, an LDL is devoid of ApoE. It's only got this ApoB on it. So LDL receptors prefer to clear particles with ApoE and ApoB on it. So all of a sudden, LDL receptors are third in line for particles that the liver wants to clear. That means LDL particles have an immensely longer plasma residence time than do Chilos for sure, VLDLs, IDLs. They're all a matter of hours. The LDL hangs around from 2 to 3 to 4 to 5 days. Wow. Now, that's not a mistake. Evolution wanted an LDL to hang around for that long. So why? And most people will say, oh, Tom, because the LDL has very little triglycerides. It's mostly carrying cholesterol. It's going to go deliver cholesterol. Almost never. Maybe in a pinch if the adrenal gland is overworking because you're in septic shock and you got to make 2 tons of cortisone today, the adrenal cortex will upregulate LDL receptors and the LDL can supply it. Gonads virtually never express LDL receptors to clear LDL particles to get cholesterol because gonads synthesize a ton of cholesterol, or if they really needed extra cholesterol, they would extract it from not LDL, but HDL particles. By the way, and this is why you could have an LDL cholesterol of 10 and have no gonadal dysfunction or no adrenal cortical dysfunction, because LDL doesn't supply those organs with their cholesterol. So keep that in mind. So here, why do LDLs hang around for so long? There's got to be a purpose, because you know if LDL particles exceed a certain threshold, bingo, right into your artery wall, creating that disease, atherosclerosis, that we don't want. So here's why an LDL hangs around, hopefully in physiologic concentrations. I've hinted that ApoA1 extracts cholesterol from any cells that is trying to get rid of unneeded cholesterol and forming bigger and bigger and bigger HDL particles. Now, everybody thinks, oh, and then the HDL just scoots it back to the liver. That's reverse cholesterol transport. Nope. Could be. And HDL can do that if it so fits, but then the HDL might be destroyed at the liver. It takes time to go to the liver. Would there be a quicker way for an HDL to get its cholesterol back to the liver? Yep. Evolution gave us a lipid transfer protein called CETP, cholesterol ester transfer protein. It really should be called CETTP, cholesterol ester triglyceride transfer protein, because it's mostly that's a protein that's carried on HDLs. But if an HDL full of cholesterol, or an HDL that it has cholesterol bumps into an LDL, that CETP, it's almost like it gets an erection, the HDL particle. CETP sticks up and it penetrates the LDL particle. So all of a sudden, the HDLs and LDLs are going to transfer their internal fluids. They're having sex with one another. So one molecule of cholesterol goes from the from the HDL to the LDL, but in return, the LDL will send a molecule of triglyceride to the HDL. So what would happen if that happens a bazillion times every minute? HDLs, which pulled cholesterol out of cells, which kept those cells healthy, prevented cholesterol toxicity, said, hey, LDL, do me a favor, take my cholesterol, you bring it back to the liver for me. And when you deplete that HDL of cholesterol, it becomes smaller, it can go acquire more cholesterol. But if the HDL acquired triglycerides from the LDL or even the VLDL in exchange, once that HDL gets a little extra triglycerides, it is subject to triglyceride hydrolysis from hepatic lipase, and that's how you create small HDLs. But good, they're the ones that can go and fill up back at the cells. Now, once the LDL has accepted cholesterol from an HDL, the LDL goes to the liver. Here are those LDL receptors. Bingo, grab the ApoB on the LDL particles and pull it into the liver. If LDLs take cholesterol from an HDL and they return it to the liver, what is the function of an LDL? Reverse cholesterol transport. That's why we evolved LDL particles. LDLs rarely deliver cholesterol to any peripheral tissues, and they can't cross the blood-brain barrier, so they sure as hell do not supply the brain with any cholesterol that the brain may need. I saw a tweet from you today that discussed that, and you were spot on. So here, reverse cholesterol transport, we all were taught, oh, it's just HDLs bringing cholesterol back to the liver then can get rid of it. Yes, HDLs can do that. That would be called direct reverse cholesterol transport. But if an HDL gives its cholesterol to an LDL and it returns it to the liver, that has been labeled as indirect reverse cholesterol transport. Total reverse cholesterol transport is direct plus indirect. And this is why looking at a serum HDL cholesterol provides zero insight as to this complicated pathway called reverse cholesterol transport. You could have an HDL cholesterol of 10, 5, and have phenomenal reverse cholesterol transport. You could have an HDL cholesterol of 160, have no reverse cholesterol transport. So we can't, doctors have to stop telling patients, oh, thank God your HDL cholesterol is high, you have great reverse cholesterol transport. Why, if reverse cholesterol transport is an HDL getting rid of cholesterol, why the hell would it be high? Doesn't even make sense to say that. So I'm going to pump back to you because I wander and I've tried to give you some of the complexities of this lipid transportation system.
No, that's incredible. I'm going to try and summarize a few things and you can tell me how I'm going, where I'm going wrong. Okay, so what I'm going to try and do is talk to the origin of these different lipoproteins, where they're coming from, summarize some of that. So we have the enterocytes, which are, I guess we can think about, you have the kind of small intestine, I guess we could say the lumen, where the food is. The enterocytes sort of separate that from the lymphatic system. And the fats and the cholesterol that we eat, as well as any cholesterol that comes back into the intestine from the liver, can be sort of packaged up into these chylomicron lipoproteins that occurs in the enterocytes and will be affected by these receptors. Some of these receptors, like the Niemann-Pick C1, N1, or I know you've spoken about G5, G8. We can come back to that later.
Yeah,
but
I didn't mention that, but that's part of the story.
Right. So there, some of that might explain why people sort of respond differently to, say, dietary cholesterol, for example. We could come back to that. But the point is that this is where the chylomicrons sort of their origin and where they're synthesized, and then they enter the lymphatic system, they come into circulation, they're providing a great source of energy particularly for our muscle cells, and they're also not hanging around a very long time, a very short residence time. And they dump off some triglycerides, they become smaller, they become these chylomicron remnants, and then they go back to the liver. And the liver can kind of recycle those or do what it needs to do with them. Then the liver, the other or the second sort of primary place of synthesis of these lipoproteins is occurring in the liver. And the liver can produce, from what I heard, I previously thought it was just VLDLs, but in reading your work, I now understand it can actually produce LDLs as well and pump those straight out. So it produces these let's say VLDL molecules, lipoproteins, pushes them out into circulation. They're now delivering triglycerides to tissues that need them. And as they dump off triglycerides, they become smaller. They then take on a new name where they're less triglyceride rich. They become IDLs. Same thing happens again. And then they can become LDL molecules. And these LDL molecules, their primary role sounds like it's to bring cholesterol back to the liver, or in a system that's working well, they're bringing cholesterol back to the liver directly through the LDL receptor, but they're also taking cholesterol off of HDL particles. Does all of that sound right so far?
You nailed it. You just left out the little crucial part about phospholipids being shed so they can go help HDLs mature, but you nailed it, Simon.
Okay, so I understand the story up to there, and actually it kind of makes me think about this entire system. When we think about cholesterol, given that every cell creates or can synthesize its own cholesterol, and you sort of pointed out that very rarely will tissues need cholesterol that's been produced by the liver, whether it's the adrenals or the testes, for example. So it kind of seems like the primary function of this system is to clear excess cholesterol from cells and get rid of it, as opposed to a system that is set up to take cholesterol out to cells?
Well, you're very insightful. I was told you're a smart guy. So yeah, and you've really analyzed this well. But and this is a higher level question, but why the hell was cholesterol even put in the Kylo or the VLDL, since it's not going to deliver it? Why, let it just accept cholesterol from an HDL and bring that back. So here's the reason cholesterol is in those particles. If a lipoprotein was not carrying X amount of lipids, it would be a flatbed truck. It'd be a small discoidal particle with no capacity to traffic other lipids. So cholesterol is put in there to make these, it's like partially blowing up the balloon with air, except the intestine and the liver partially fills up the chylos or the VLDLs with cholesterol, but they leave a lot of space for triglycerides. So cholesterol is just performing sort of a stoichiometric principle of making big lipoproteins spherical. And even the HDL does start off as a protein, so it is a little flatbed truck. But that can only carry 10 or 15 molecules of cholesterol. That would solve nothing. But as the HDL acquires cholesterol and the phospholipids, it evolves from a discoid particle into a big round spherical HDL that can carry a significant amount more of cholesterol. So cholesterol is basically helping shape and create the volume in lipoproteins. It's not put in there to go be delivered somewhere. Yes, in an emergency, it could deliver it, but that emergency rarely arises, until we're dying and, cancer, they need cholesterol. So then they start being internalized or so. So that's why cholesterol is there. It's just keeping these balloons partially filled up so they can gather either more cholesterol or triglycerides.
Mm-hmm. So we can kind of put to rest this idea that if you want healthy hormone production and healthy levels of cholesterol in your cells, then you want to have a high serum blood cholesterol.
You want to have great cholesterol production within the gonads or the adrenal cortex. Thank God the brain is a cholesterol synthesizing machine, so it doesn't need any cholesterol from your blood. So that's how those organs survive and make hormones. They synthesize de novo cholesterol. And, all they need there is some acetate or citrate, which is the initial building block for cholesterol synthesis. So they have no shortage of substrate from which to build cholesterol.
In my summary, I left out one important piece of information that you spoke to, and that is the importance of that main protein that wraps around these lipoproteins. So the chylomicrons, the VLDL, the IDL, and the LDLs have this ApoB. As I understand it, they're slightly different ApoBs, but for now we'll just call it ApoB. And the HDL has ApoA.
A1. There's several types of Apo. Capital A. A1 is the structural protein. But a little distinction, the beta lipoprotein family, the ApoB particles have one molecule of ApoB. HDLs contain from 1 to 4 molecules of their structural protein, apoprotein A1. And that's why you can't measure ApoA1 and get an accurate HDL particle count. But if you measure ApoB, you get a very accurate ApoB lipoprotein particle concentration, 1 peptide per particle. HDL's 1, 2, 3, or 4 peptides per particle.
You mentioned before threshold and physiological norm. So talk to us about that. When this system is working well, these LDL particles or any of these ApoB containing lipoproteins are sort of finding their way back to the liver and not ending up in the artery wall and depositing cholesterol and building up as plaque. Is that safe to say that when this system's working well and we're at a physiological norm level, that's not happening?
Perfect. And I think early in my diatribe here, I mentioned physiological concentrations. If we can keep these particles at the proper concentrations, they will perform exactly as I said they should, because all of those machinations will happen. But if the ApoB particle concentration, and remember 1 ApoB per particle, if ApoB measurement in the blood exceeds a certain level, there are more ApoB particles circulating than the liver is clearing. And as that number goes up and up and up, the particles are obviously not being cleared by the liver. So where do they go? We have miles and miles of endothelium on our arteries. So they just pick the nearest artery and they crash it. And the ApoB particle carrying cholesterol, step one of atherogenesis is it passes through the endothelial lining, which is a one-cell lining of every artery in our body. And now it's in the artery wall. And we can talk more about that later, but that's step one. But what forces the ApoB particle to go? My joke is it's going to go where it's going to do illegal dumping. It's not going to the liver, which can get rid of the darn cholesterol safely. It's putting cholesterol in your artery wall. And the primary driving force is particle number, particle concentration. And this is why ApoB is by far the best metric that every human should get tested for when they do their cardiovascular risk assessments. Most of them get other lipid concentrations, and we'll relate the two later on. But once your ApoB goes above a certain concentration, the chances are good it's going to crash your artery wall. There are other things that influences whether it goes into the artery wall or not, but it's particle number. Very few people who have physiologic numbers of ApoB particles ever get atherogenesis or atherosclerosis. And here's the bad news. You know, our little kids don't get much atherosclerosis that we know of. Some of them do nowadays because they're eating this junk earlier and early and getting fat and insulin resistant at very young ages, which didn't happen earlier. But these ApoB particles, if you took a 5-year-old and measure his ApoB, it's 40 or 50 milligrams per deciliter. That's a physiologic. When we come out as infants, it's 20 to 30 milligrams per deciliter. And by the way, when we come out of mom as little infants, our brains are fully developed and there is virtually little circulating cholesterol in that fetus while he was in the uterus, and very little in the infant once he's born. Yet the brain keeps developing normally for several years, even though there's very little cholesterol in the ApoB particles in the brain. So there's another thing that tells you stop relating blood cholesterol to brain, whatever's going on in the brain or so. So now, as you know, as we get older and older, you get into adolescence, puberty changes the concentrations of these things. Worse in men before women. So, sooner or later, ApoB may cross the threshold from which it has the ability to start crashing your artery wall. Now, listen, if you took a 14-year-old and he's got ApoB particles, unless this kid has astronomical levels as certain genetic lipid disorders, it would take 3 decades for enough ApoB particles to pollute his artery wall with cholesterol before he might show up with a positive coronary calcium test, or even 4 decades before, like your dad, he suddenly gets chest pain and while driving or doing something else. And this goes back to how we started off this thing. God, if we would just measure ApoB early in life, we would know, whoa, let's start a better lifestyle in this kid, some exercise, not let's start 3 drugs to get his ApoB under control. We would halt atherogenesis before it's ever even beginning. But most people don't do that. Most doctors don't check that in young people. So even though atherogenesis may be occurring, and God knows through all the wars we've been through and our young heroes get shot, killed, and autopsied, so many of these 18 to 22-year-olds have significant non-clinical, meaning symptomless atherosclerosis in their arteries because ApoB has been crashing their artery walls for 18 to 22 years already. So we got to recognize it early. But this is why one of the reasons why ApoB is considered causal, because it's a marker of the particle that is carrying cholesterol, which is actually the injurious molecule to the artery wall. But no cholesterol could ever get into your artery wall unless an ApoB particle dumps it in there. So this is why ApoB has gone to center stage with the best marker. And if we exceeds whatever threshold you think is necessary, we'll start treating it and return it to those physiologic levels. And that's therapeutic lipidology in a nutshell.
So 40 to 50 milligrams per deciliter is the kind of concentration of ApoB in young humans.
Yeah, and if they could
what is the
maintain
threshold?
that, they will virtually never have atherosclerosis.
What do you think is the kind of the tipping point threshold where you go from a level of these ApoB containing lipoproteins that's not causing atherogenesis to where it's beginning to?
A lot depends on what other risk factors is present in you. Now, if you had nothing else wrong with you but ApoB, it would take longer than if you were a smoker who was a diabetic, who was a hypertensive. It'd be a much shorter time before you've got atherosclerotic plaque in your arteries. So here's the levels. In general, if there are not a bunch of other risk factors of concern, we like people to be in what's called the bottom 20th percentile population cut point. In other words, if we measured ApoB on every human on the planet, let me see the people who have an ApoB concentration that is in the lower 20th percentile, and that would be 80 milligrams per deciliter. So in general, unless you do have a multitude of other factors, if you're running around with an ApoB of 80, that's probably fine. It's going to be a long time, and sooner or later you're going to eat wrong or start smoking or secondary smoke. So you want to be lower than the 20th percentile. But that's on average. You never want to be much higher than that. You certainly don't want to be above the 80th percentile, because that's like 115, 120 milligrams per deciliter. Those are the people who most commonly get atherosclerotic heart disease. Are there people with super high ApoB who don't seem to get atherosclerosis? It's the biggest risk factor. It's causal. But yeah, there's always going to be an exception to the rule with human bodies. And what is preventing in my very small minority of people horrendous ApoB not causing atherosclerosis? Nobody knows. There must be other protective things going on. But nobody who's measuring their ApoB at age 30, 40 and says, oh, my ApoB is 140. I ain't worried about it because I'm good. I'm healthy. I can do 50 push-ups a day. I actually did a coronary calcium and there's no calcium. Well, that's good. You probably got another 5-10 years where nothing's going to happen to you. But if you're 30 and 40 and you want to see 90, I wouldn't go 50 years with an ApoB that's sky high, because there would be zero data supporting that is safe.
I have a few more questions on some of that stuff, but I want to dive in a little bit more into the mechanism, if that's all right with you. And the term transcytosis comes up a lot in the literature, which essentially, to my knowledge, just means the movement of these ApoB containing lipoproteins from the plasma, like in the lumen of the artery, in that inside of the tube, through the endothelial sort of cells or between them into the intima, which is the innermost kind of part of the artery wall. Is that sort of flux, transcytosis, movement of these ApoB containing lipoproteins into the artery wall, is that normal and happens all the time, and they go in and they sort of find their way out and nothing happens, and it becomes pathological when they don't find their way out and become retained for some reason?
Yeah, so now you're going to look at, all right, ApoB has somehow gotten through that endothelium, and I'll tell you the ways it does that. But then it's in you called it the intima. That's basically the outer connective tissue area of the arterial wall. And there are reasons why that ApoB particle, once it passes through the endothelium, it's going to get stuck there. That ApoB protein on the surface of the particle has great affinity for connective tissue molecules, glycoproteins that bind the ApoB particle, and it's like a flies on flypaper. It's stuck. Now, sometimes it's just stuck there and nothing ever happens. Who cares? Very few of them break free and can leach out again back into the plasma, perhaps a minuscule number. But once they crash there, they're stuck in the arterial wall. So as they're bound to these proteoglycans in the arterial wall, they can just be bound there forever. And like a mummy, they'll just ultimately shrink up, add to the connective tissue, and they're of no consequence. Because for atherosclerosis to develop, ApoB cholesterol-containing particle has to be ingested by a macrophage that is in the arterial wall connective tissue. How did the macrophage get in there? A monocyte left the bloodstream. It passes through the endothelium. There are receptors that pull it in, and it transforms into a macrophage in the arterial wall. A macrophage is basically a white blood cell capable of scavenging, eating things. So what makes some of the retained ApoB particles a substrate for receptors on macrophages that they will internalize them. And now, if that macrophage keeps internalizing humongous numbers of ApoB cholesterol-carrying particles, before you know it, the macrophage becomes super cholesterol engorged. They're called foam cells because they look foamy if you look at them in a microscope. And that, if you get a macrophage that turns into a foam cell, and you get a few billion of those macrophages, that is plaque. Initially a fatty streak in the artery wall. After that, more localized collections of cholesterol. And over time, they get bigger and bigger and bigger. Most of the disease early on is in the wall of the artery. It's not obstructing the arterial wall lumen at all. Sooner or later, bad things can happen. But the million-dollar question is, after the ApoB particle goes through the endothelium, why do some get ingested by macrophages and others do not? A word first about what you said, the transendothelial passage, transcytosis of the ApoB particle. That can occur with perfectly healthy endothelial cells. You do not need an inflamed, disturbed endothelium for that particle to pass right through it. Caveoli, and there's other receptors that just pull those particles through. There is a little gap between endothelial cells, a perivascular sort of channel. They can sneak through that. These are very, very small particles, 20 micrograms, 21 millimeters, they get in. So, but they certainly can get in with greater frequency if the endothelium happens to be disturbed or inflamed. And most of the inflammation of the endothelium in atherosclerotic disease is because those macrophages I told you about, they start ingesting the particles. They start secreting all these pro-inflammatory cytokines, chemokines, which causes the endothelial dysfunction. So it's ApoB is not bad enough. It's delivering the criminal cholesterol, but then that sets off the inflammation that further destroys your endothelial cells. But there are many human conditions where the endothelial cells might be inflamed before the ApoB particle even shows up. Many of our collagen diseases, you know, the list of subtle inflammatory diseases are huge. Even insulin resistance, diabetes. Yeah, think of the people who have subtle elevations of C-reactive protein. Likely many of them have this. Now they have an endothelium that has less protection in keeping an ApoB particle out. So, but it doesn't have to be there. And that's why the young people develop atherosclerosis early, because they're not having all these inflammatory conditions. Particles just go right in. So who cares? If a particle gets in, you're in trouble. Whether the endothelium let it in physiologically or you got a destroyed endothelium due to other factors.
Is that also where risk factors like high blood pressure and smoking play a role? Do they feed into this, the sort of quality of the endothelium? Even
I couldn't give you a list of the pro-inflammatory conditions that probably cause endothelial dysfunction. Hypertension and its effect on nitric oxide would be one. Smoking for whatever chemicals are passing through your endothelium there, of course. Autoimmune diseases where the immune system is revved up and creating so many undesirable things. I mentioned insulin resistance, diabetes is a pro-inflammatory state. So the list is long. So try not, if you have high ApoB, try not to have any of them.
The take-home message there, though, before we move on to the next point, is that you're always going to have some movement and flux of these ApoB-containing lipoproteins from circulation into the intima. You can exacerbate that and make it worse if you have other kind of risk factors or genetic sort of conditions. But it's going to happen because I do think there is this idea out there that, well, if my endothelium is healthy, it doesn't actually matter if I have elevated levels of LDL cholesterol.
Unfortunately, that is circulating all over the internet. They go out and they do some inflammatory marker in the bloodstream and it's normal, and they declare themselves immortal. It's silly. High ApoB. Listen, FH, which is a genetic condition of too many ApoB particles that certainly causes premature atherosclerosis is not typically associated with inflammatory markers. But those are big ApoB particles that have no trouble just passing through the endothelium because their concentration is so high. So yes, it's always a complicated story, but never ever say, yeah, ApoB high, that's bad, but if I don't have inflammation, I can't get atherosclerosis. Sooner or later, you will have inflammation because once the particle goes in and gets ingested by the macrophage, boom, now you have a pro-inflammatory state, and then the endothelium will become dysfunctional at a certain point as cholesterol gets deposited. The next step would be the particle going into the macrophage, but go ahead, finish.
Yeah, that's what I'm interested in, the next step. And I guess one of the kind of first questions I have here is, do we have any sense for the percentage of ApoB containing lipoproteins that do undergo transcytosis, cross into the intima, and move back out versus become retained?
Well, I haven't ever seen anything that the number that leak out. People mention it, but I've never seen quantitative studies showing that or so. I think most of them at a threshold, if they do somehow pass the endothelium, they either get caught there and they just rot away and contribute nothing to the buildup of cholesterol and macrophages. But there are some that get transformed or develop the ability that the macrophage is going to grab them and ingest them, which would create the sterol-laden foam cell. So that's the step one of, if all that happened is ApoB particles crashed your artery wall and bound to proteoglycans, I don't think we'd have atherosclerosis. How many do that? I don't have a number for you. It's considerable, but we have such high concentrations of ApoB. There's plenty that are going to make it to the macrophage and not just simply be an isolated, stranded LDL particle in your artery wall.
So if we kind of think about two ApoB containing lipoproteins here, I'm simplifying this, and one of those let's call Peter, and the other one let's call Mary. And one of these ApoB containing lipoproteins enters the intima, it binds to proteoglycans, but it goes no further than that. And that's what happens to this molecule called Peter. This molecule called Mary goes in, binds to the proteoglycans, and then it becomes modified and it gets taken up by macrophages. What is it that differentiates why that happens to one versus the other?
Right. So what makes a retained ApoB particle become a substrate for the macrophage, endocytosis? Something has to happen to differentiate those two particles that came in. Why the one? And so it does have to be transformed. Now, for the longest time, people just said, oh, the particle goes in, it's subject to reactive oxygen species, the surface phospholipids get oxidized, and oxidized lipids are a major thing that sets off scavenger receptors in the macrophages, and the particles get intensified. And there's a lot of animal data that shows that, and there's very little human data that shows that. And this is a problem. So Peter Libby is the expert on this, and Peter Libby has been writing in the last few years, if oxidation occurs, and that's an if, because there's not a lot of human data supporting it, what else would make an LDL particle very attractive to the receptors that internalize it on a macrophage? Something has to happen to that particle. Or maybe this next step that I'm going to tell you about happens and then oxidation happens. So there's a precursory step to oxidation if that occurs. And by the way, the reason Peter questions that is that there have been several trials of various antioxidants given to people, and none of them have reduced atherosclerotic heart disease. And some of them prescription grade probuccal antioxidants that just didn't do anything. So who knows? But here's the now believed to be the crucial first step. So what's on the surface of a retained ApoB LDL particle? Phospholipids. Now, phospholipids certainly can be oxidized, but what happens is there's, in some LDL particles, there's a rearrangement of the types of phospholipids that are on the particle. And there are certain phospholipids that are targets for the receptors on the macrophages. Sphingomyelin, ceramide, and how does the regular phospholipid content, which is mostly phosphatidylcholine on these LDL particles, suddenly change into these other phospholipids that become attractive? There are enzymes called mutases, and these mutases have the ability to change fatty acids on the phospholipids, changing one phospholipid into another. And if you create the wrong type of phospholipids, what now happens is the LDL particles, and there's many of them stuck there, they bind together. That's called aggregation. And sooner or later, you get a bunch of LDL particles because their phospholipids have this new attraction for each other. You get humongous collections of aggregated LDL, and it's the aggregated LDL that gets internalized by the macrophage. So instead of it internalizing one LDL particle, it's internalizing hundreds of aggregated LDL particles. Now, once the particles are aggregated, does some degree of oxidation occur there? Maybe, probably, who knows? But aggregation seems to be the crucial step that sets off the cascade. And there are papers written on this. I can send you nice slides, which maybe we will put into your slide notes. Remind me as we get to that stage of promulgating this message tonight. So it's aggregation of LDL particles. And if you have an aggregated clump of LDL particles, there are a hell of a lot more cholesterol molecules in that than there would be in one LDL particle. So bingo, aggregation. How much role oxidation plays after that, I like always, we need more studies, and human studies, especially not what happens in a mouse. So, because that may or may not have applicability to humans. So that's the big step, this whole new concept of aggregation of particles. And then you have the macrophage. Once that all those sterols are in the macrophage, they start creating interleukins and all the other things that then leach out into the plasma, go to the liver produces C-reactive protein, or the chemokines, cytokines, some of them that are produced as they try to leave the artery wall, they damage the endothelial cells there, creating endothelial dysfunction. And if we don't arrest this process by forbidding ApoB particles to enter, and the only way you do that is reduce their concentration over time, and time is critical here, years and decades, they're your father. That's what happens.
The critical point being here that in order to stop that process of retention and then modification being taken up by the macrophage, turning into a foam cell, building up as fatty plaque, we have to get the concentration of these ApoB containing lipoproteins, which are mainly your VLDLs, IDLs, and LDLs that are in circulation for longer.
Well, let me stop you there. It's mostly LDLs. The VLDLs have a plasma residence time of a few hours, chylomicrons less than an hour, IDLs an hour, LDLs several days. So when you measure ApoB, 90 to 95% of your ApoB particles are LDLs. So yes, a VLDL or a chylomicron remnant can make its way into the artery wall, but it's like, 95% of the army is LDL particles that are doing the invasion. So and that's good because it's very easy to modify LDL particle concentration with various therapeutic maneuvers.
Quick one. To help support this series, my team and I are putting together a lipid series summary PDF with the key learnings. If you'd like a copy of this, please register your email at theproof.com/lipid series. That's theproof.com/lipid series. Okay, back to the show. And that's interesting about the role of phospholipids here. And it gets me thinking because not only do we hear people say, well, if the endothelium is intact, then you don't have to worry about high LDL cholesterol. But the other thing that I often hear, and now I've got all sorts of questions about this, is people saying, well, if your oxidized LDL is low, and people say things like if you don't consume certain oils, you don't have to worry about oxidation of LDL. But
by the way, there are no oxidized LDLs floating in your bloodstream of any consequence. They would immediately be removed by all of our immune systems that get rid of oxidized particles in the blood. Most of the particle oxidation occurs in the wall of the artery, and that is not measurable.
That's the really interesting point that I was thinking about, because people talk about measuring their oxidized LDL.
Listen, I worked with a biomarker lab for 7 years, and all that did was make the laboratorians rich. It's a totally useless metric to measure minimally oxidized LDL in the bloodstream, because there are just none of them there. And none of the studies that ever suggest that oxidized LDL is a good biomarker were ever adjusted against ApoB, because it would have no meaning if you adjusted for ApoB.
Mm-hmm. Okay, so the oxidation is occurring in the intima for the most part. It's not occurring in the circulation.
Yeah.
So
now we will, sooner or later, we'll talk about Lp(a) particle. There is a measurable oxidation biomarker. It's called oxidized phospholipids on ApoB. That is in the plasma, and that is measurable. But that's not what's measured when people order oxidized LDLs. There's a very unique new biomarker that pretty much pertains only to Lp(a) particles. So I'm sure we'll get to that ultimately. But the standard oxidized LDL tests that laboratories offer are a joke. They're a way to lab make money. I doubt insurance companies cover them. They never used to when I worked there. So don't waste your money.
Is the modification of the LDL particle, is that something that is in our control? The oxidation that occurs in the intima, or the production of these I think you said the wrong type of phospholipids, are these things that are in control through diet, through the consumption of antioxidants and vitamin E and polyphenols, things of that nature?
Listen, that would be speculative. It's a good hypothesis. Nobody's ever going to do the type of trial to ever nail down those hypotheses. So, look, I think we're always going to be supporters of healthy lifestyles, which help our tissues in so many ways, including reducing atherosclerotic disease. But how exactly they do it? Are they messing with all that stuff going on in the artery wall? Maybe. It's plausible, but I don't know how you ever prove that.
Mm-hmm. And you mentioned that it's the retention of the particle and the modification that really revs up the inflammation. Another idea I've heard out there.
Modification is aggregation, then probably oxidation, then you're in the macrophage.
Mm-hmm. Another idea that I've seen floating around is people suggesting that the LDL particle is actually being sent into the intima as part of the inflammatory response to resolve it, that it's part of that immune response, which is the opposite of the order of events that you're describing. Have you heard that?
Yeah, because first of all, tell me what an LDL is carrying. An LDL is a collection of mostly cholesterol, surface phospholipids, a single molecule of apolipoprotein B. There might be some minuscule concentrations of other lipids in there. Even LDL mostly it's VLDLs carrying it. There might be a little vitamin E on an LDL, but there's nothing an LDL carries that is protective with respect to that avenue of resolving inflammation. That is absurd, because the evidence that shows high ApoB is causal for atherosclerotic disease is so immense, we'd have to have a 1-week podcast, if I could even remember all the trials that have proved it, of many nature trials. So it's silly for anybody to even argue that nowadays. Yes, as we mentioned, there are probably the oddball person here and there where somehow they made it to the centurion mark and their ApoB was high. They'd be few and far between. And I don't know what in their body protected them against ApoB, and neither does anybody else.
So if we want to keep inflammation down in the intima, we essentially want to reduce the amount of cholesterol that's being deposited there.
Yeah. Stop the ApoB particle from going into the artery wall, and that will arrest a significant amount of arterial wall inflammation. It depends at what stage of game you start doing it. If we take somebody like your father, who probably had a lot of significant I don't know that we ever put out the fire in his artery. We can certainly reduce it. But earlier in life, yeah, I think if you stop ApoB from going in there, there will be none of this maladaptive inflammation that occurs in the artery wall. It's just so sensical.
What is it that differentiates veins from arteries? Why do we tend to see more of this fatty plaque build up in the arterial system?
Yeah, well, first of all, veins don't have the same construction in the arterial wall, but it's such a low pressure system. So blood pressure in the arteries, this is where blood pressure starts factoring in. And also arteries are tortuous. They're kinked, they bend, and atherosclerosis doesn't develop in every square inch of an artery throughout your body. There are certain key locations, and it's almost always where blood is coming hard and it has to make a right-hand turn or a left-hand turn. And that would, you can imagine, facilitate like ApoB particles are coming out of a shotgun. So, in King City, and veins just don't have that. Veins are just, there's almost no pressure in them, and it's just vaguely blood flow going around. There's nothing, because obviously the particles are in the veins too. So, but that's the difference. Veins are subject to thrombotic complications, not atherosclerosis. By the way, interestingly, we used to take saphenous veins out and do coronary bypasses with them, and now you're putting a vein in an arterial milieu, and those veins can develop atherosclerosis. So, but if you keep a vein where it's supposed to be, there's no atherosclerosis.
Okay, so that's the mechanism side of things.
Yeah.
Is there anything else you want to add there?
Rheology, blood flow, and blood kinetics, which are certainly part of. No, it's the ApoB doing it, but why does ApoB selectively deposit at certain areas in various arteries?
Mm-hmm. You mentioned before that there is a plethora of evidence that establishes ApoB as causal in the development of atherosclerosis. And I appreciate we're not going to step through all of that body of literature.
Please, because I'll develop a headache and have to go.
But if someone said, look, Tom, summarize, that evidence that we have, where would you start?
Well, you'd start with just generalizations. You would say, here is the evidence. Epidemiologic studies, not the highest proof, but if they're 95% suggestive of a plausible reason that they're probably true. Now you have randomized controlled clinical trials where you actually control for things and you change ApoB or something during a trial, or you do a randomized study following a cohort for a long time. So, and then you get into the genetic studies. If you look at genes that are associated with atherosclerosis, and then you can do this Mendelian randomization where you can play with, high LDL cholesterol, low LDL cholesterol, high ApoB or not. Let's look at all the genes that we know cause atherosclerosis or do not, and let's see, does whatever metric you're looking at matter in these genetic, because the Mendelian studies are basically a lifelong randomized controlled trial. Nobody can putz around with anything. You got your genes, and if you got the genes that make ApoB or prevent ApoB from being cleared, you're going to go through life with high ApoB. If you don't have those genes, you're not going to have high ApoB. And we can just look at these gigantic studies and relate. And this is how some things ultimately get called causal. So you have all of these studies, and we're going to link it in your podcast notes. About 3 years ago, the European Atherosclerosis Society put out 2 gigantic papers on the causality of ApoB, where they do chart every damn study in the history of the world that does support it. So for the geeks who want to read every darn paper, now listen, I grew up through this era. I lived through all of these papers, but my 77-year-old brain doesn't remember every chapter and verse of every damn study that's ever been done. But they're there. There's not a guideline that exists now that doesn't cause ApoB causal. So the deniers think those are all experts bought off by pharma or something else, laboratories, which is ridiculous, but that's their excuse, not to argue the facts, make up stupid stuff as to why it can't be true.
Yeah, I believe you're referring to the Brian Ferentz and the Boren papers. So those, I've learned a lot from those. So we'll definitely put those into the show notes. Linking back to our earlier discussion. So I'm interested here in kind of how someone can determine whether their ApoB level or LDL cholesterol level is, if let's say it's elevated, is elevated because of genetics, or is it because of their lifestyle? And if we just start, you mentioned there's some genetic variants that can result in, I guess, an elevated level of ApoB or even a reduced level of ApoB and offer protection. And going back to where we were talking about the lipid transport system earlier, most of these genes either affecting the ability for LDL to come back into the liver or affecting the amount of cholesterol that's absorbed in the intestine?
Well, listen, I think where we're all going in this science right now is this so-called polygenic risk score that people are developing. You get an extensive genome analysis, and we certainly don't know what every gene does, but there's enough of them that we know, hey, these genes are associated with atherosclerosis or atheroprotection or just null. And if you can look at all those SNPs in a given person, you could just say, geez, you have a hell of a lot more SNPs associated with atherosclerotic risk than the guy we tested down the street who we didn't find any. So if you have an abnormal polygenic risk score, then we all ought to get that test early in life. And if you're abnormal, you have some of the genetic risk things, that's when you start then monitoring closely the causal things that nowadays we can treat. And that would start with ApoB. We'd certainly, again, tell you to stop smoking, control your hypertension. But that's the way we're going here. So, look, I'm coming more and more to the belief that every lipid disorder has an underlying genetic abnormality. Now, yes, the genes always act with the environment in which they're placed. So, depending on which genes you have, maybe if you lead a perfect lifestyle, you might be home free at the end of the day whenever death does come. But the odds are how many of us do the perfect lifestyle? So if you got a couple of genes that don't like what environment you're exposing them to, bingo, you develop it. So one of the treatments would probably be a healthy lifestyle. But I think behind every lipid disorder, if you didn't have the genes that can cause whatever you're measuring, you're home free. Maybe you can eat whatever the hell you want if you had zero of those genes and be a couch potato all your life. Maybe there'd be other morbidities related to your bones and muscles and arthritis, but you probably wouldn't get atherosclerosis. So genes, as we're now learning, are more and more. God, this is how pharma exists nowadays, because every time they identify a new gene that seems to be seriously involved, what protein does that gene make? You go in there and you inhibit it, and bingo, you got another drug that is a piece of the puzzle of wiping out atherosclerosis. And old men like me, we're taught nothing about genetics for the most part because we didn't know anything. And now, if you want to be successful in this field, that's why I'm certainly a lot closer to retirement. I'm glad, because I can't keep up with all this genetic information. So genes are everything. One day, these polygenic risk scores will be certified as being what we think they're going to be right now, but the data is pretty good now.
That reminds me of a question I have. Often I hear people suggest that, well, if you lower ApoB, you might reduce your risk of atherosclerosis, but you won't increase your lifespan. You'll just end up dying of something else. And I'm wondering, if we look at, say, I'm not sure if you've seen this, but if we look at, say, a gene mutation like a PCSK9 loss of function, so these people have really low levels of ApoB and reduced risk of atherosclerosis, and they have that lifelong, so they're born with that. Do these people show greater longevity? Do they live longer?
There are a couple of studies that have related ApoB to longevity, and we'll certainly list the papers that show that. But in general, I don't know that we have enough data on that now to say it with certainty or so. But listen, longevity there's two components to it. Yeah, we all want to live as long as we can. And the next thing is we want to live disease-free. That's health span. You want to, if I'm going to make it to 90, I want to be able to think, have a heart that beats, be able to walk without a walker. So we have to work hard at preventing the degenerative diseases. I think we can take out atherosclerosis. So maybe I don't live too much longer. I think you'd live a little bit longer, but is that a guarantee you're going to make it to 100? No, because these other diseases can pop up and then take you out. Right now, if longevity means taking out atherosclerosis, which I believe we can do, hey, taking out cancer, taking out degenerative brain disease, and then taking out a bunch of metabolic diseases that can do us in too. And then buckle your seatbelt after that. Certainly falls is what kills the old folks like me. So early in life, we all ought to be training our muscles and skeletal system a lot better. So, but atherosclerosis, even if it doesn't, you're not going to live a day longer. You're not living in congestive heart failure. You're not living with, I can't take 3 steps because I get chest pain. You're living without TIAs. The risk of stroke is near abolished. Claudication, I don't ever have to worry. My renal failure is going to be due to atherosclerosis. I won't be developing an aneurysm in my aorta someplace. So that's kind of cool. Even if I don't live longer, none of those are morbidities you want to ever have to deal with. They'll bankrupt you. They'll certainly cause life to be a bit miserable. You'll be in and out of the hospital. So, yeah, who cares whether you live a day or longer? I suspect we will, but I know for however long you're going to be here, the morbidity of heart disease will be gone.
Yes, quality of life. I have a question around the mechanism by which ApoB is elevated, and whether, and I think I already know the answer to this question based on you describing atherogenesis and the cascade of events that occurs. But there is this idea out there that the mechanism by which ApoB is elevated somehow affects the quality or function of those particles and the ability or lack of ability of those to end up becoming retained and modified and being taken up by a macrophage. Is there a chance, for example, that ApoB containing lipoproteins are acting differently in people who have, say, familial hypercholesterolemia versus someone who has those same elevated levels of LDL cholesterol but through diet?
Yeah, there are definite studies that show if you come in with ApoB levels or LDL cholesterols that put you within the definition of familial hypercholesterolemia, and you would also, by doing a family history and other ways, make that diagnosis with certainty. But then you might start doing a genetic analysis and say, hey, your LDL cholesterol is 290. Let me find out what's wrong with your genetic system. Why is your body not getting rid of these LDL particles? So if you do a genetic analysis and you find especially a monogenic disturbance as to, no wonder you got too many ApoB particles, versus the next person who has the same very high LDL cholesterol, but your genomic screen comes up negative, the person that you've actually found the genetic mutant does have higher risk than the person who doesn't, even though the phenotype LDL cholesterol is exactly the same. But here's the thing, they're both at immense risk. It's not like, because you didn't find a genetic defect in me, I'm home free. That's nonsense. There's so many genetic defects that are yet to be discovered in everything. The monogenic defects are the worst. So now there's other thing too. If you have a bad gene defect, genes all interact with one another. Are there other genetic things going on that perhaps worsen your risk too? But there's nobody who has the ApoB level or LDL-C in the FH definition range that is ever should be told ignore just because we can't find a gene that causes it. So yes, I'm sorry, sir, we did find a genetic defect in you. You're at higher risk. But the good news is you're going to take both of those patients and using modern therapeutic modalities, restore their ApoB level to physiological levels, and then the risk disappears, no matter what the hell the genetic cause is. And that's the good thing. You really have to know the genes that are causing it. You just have to get the ApoB under control. Sometimes knowing the genetic defect plays well with the third-party payer because the drug you're probably going to need is super expensive. And if you can show the third-party payer, oh, look at this gene I got, they'll cover it. Whereas if you can't show a genetic abnormality, they might hold that against you. More and more just using the LDL cholesterol level and associate them with other risk factors. But yeah, so it does. But it's not like, oh, thank God we didn't find a genetic reason for your sky-high LDL-C. You're protected. Nonsense.
Mm-hmm. Okay. Well, that clears up, I guess, your view on some of these folks who I guess fall under the umbrella of this lean mass hyperresponder.
Yeah.
Concept.
First of all, it's an absurd term. Most of these people are not lean that have this guy. That's why they went on the ketogenic diet to begin with, to lose weight. So, but it's just absurd. That's a very high ApoB state. And interesting, if you came to me tomorrow and you showed me your lipid profile and your LDL cholesterol is 280, I don't say you have FH. The first thing I must do is rule out secondary causes of hyperbeta lipoproteinemia, severe hypothyroidism, renal disease, certain liver diseases do it. And of course, certain diets, especially the ketogenic diet, do it. So if you told me, oh yeah, I'm in ketosis all day long, I'm not going to say, oh my God, it's caused FH in you. It hasn't. It raised your ApoB through mostly the high fat shuts down your LDL receptors. You stop clearing LDL particles, or it induces cholesterol synthesis. So I would modify your diet, and then your LDL cholesterol would fall far below an FH phenotype. So you always must rule out the secondary causes, of which now that the ketogenic diet has become more and more popular, we actually, as lipidologists, see more of that than we do hypothyroidism or renal or liver disease.
You say high fat. My understanding, and you may have just been saying it for simplicity, but my understanding is that saturated fats and polyunsaturated fats have a different effect on the LDL receptor.
I speak fast. That's an extra word to put in your saturated. So,
okay.
It's that's the culprit. It's saturated fat.
Right. So people need not necessarily need to adopt a low-fat diet, but need to think about, I guess, the type of fat that they're consuming. So that's fat.
Or they could say, I love this diet. I feel great on it. I've lost weight. Please control my ApoB with however you do it. And I could therefore say, stay on your damn diet and let's try this combination of therapies. It's been my experience that they're tough to treat with drugs because they're, you got drugs removing it, you got other factors going on that are increasing it. So the right hand is fighting the left hand. So, but it could be worth a try.
Why is it that saturated fats downregulate the LDL receptor sensitivity and polyunsaturated fats upregulate it?
It has to do with what regulates all cellular actions are nuclear transcription factors that sense disturbances in the cellular milieu. And there are several lipid sensing nuclear transcription factors. The sterol regulatory element binding protein, the liver X receptor are at the top of the list. One senses too much cholesterol, one senses too little cholesterol, and dependent therefore whether a cell needs cholesterol or doesn't, it goes into the genetic, the DNA, and say, hey, make this protein that gets rid of cholesterol if you have excess, or if you need cholesterol, make this protein that will help the cell gain cholesterol. So it's nuclear transcription factors, especially the two I mentioned, sterol regulatory element binding is SREB, and liver X receptors, LXR. It's in every tissue. It got discovered in the liver, so it got that name. And they regulate the genes that modulate cholesterol homeostasis. And saturated fat is sensed by the one of the sterol regulatory element binding proteins that goes in and it shuts down your LDL receptors because it's telling the liver doesn't need more lipids. So don't produce LDL receptors and pull more lipids into the damn liver. It'll worsen the fatty liver we're going to get. So it's all controlled by genes and these sensors that control genes.
Let's finish on two other components of diet and how they interact with this system. So fiber and dietary cholesterol. I'm interested in getting your thoughts on. So firstly, what's the mechanism by which fiber can help lower cholesterol levels in the body?
I think it's two reasons. One, it can to some degree, bind cholesterol in the gut and get it out of your intestine before it's less readily available for absorption or incorporation into biliary micelles. And the other thing, I think fiber probably has some regulatory effect on some of the microbes that are in our gut. And one part I want to get into, maybe when we start discussing absorption in a little more detail, how if gut bacteria change cholesterol to cholestanol, sounds the same, cholesterol, cholestanol, one's a sterol, one's a stanol. Once you make a stanol, it cannot be absorbed by the Niemann-Pick C1-like protein. So if our bacteria do us a favor and any free cholesterol that's in our gut lumen gets converted to cholestanol or its isomer called coprostanol, it's going to go out your rear end. And I wouldn't doubt that fiber has some influence on what microbes exist and where, and that's just been a theory of mine, maybe, and I don't read much on the intestinal microbe and that sort of stuff. I got too much to read on inside the body. But, to me, it's a plausible way, perhaps. So you'll less cholesterol available for absorption with that. And probiotics is just more evidence that the bacteria you put down there can change cholesterol to cholestanol. And the lactobacilli are the ones that do this. And if they start changing cholesterol to cholestanol, it's going out your rear end. It's not going to be absorbed. And they are one of the supplement ways of trying to reduce cholesterol, at least absorption. Now, look, fiber, the lactobacilli, they might impact your ApoB, your LDL, but trivially. It's nothing that's going to take you from FH to goal. Yeah, but hey, if you want to make that as part of a regimen, okay. I don't see harm to those two therapies.
Mm-hmm. Talk to me about why it's hard to answer with a yes or no if someone says, is dietary cholesterol going to significantly affect my blood cholesterol levels, or can I eat eggs? So let's go into the kind of the way that dietary cholesterol is absorbed and some of the genetic differences that people may have.
And when you get into science and lipidology especially, I've written 2 book chapters that are like 50 pages that deal solely with the absorption of sterols in the gut. And because there are like 10 stages of it, we've hinted at it. You swallow cholesterol. You vaguely mention that a ton of cholesterol is coming out of your bile duct because the liver put it there. That's most of the cholesterol in your gut. But then you have to put it in a biliary micelle, and then that micelle has to be, the sterol has to be absorbed. We didn't talk about, you vaguely mentioned it, boy, if the Niemann-Pick pulls in too much cholesterol, we got a cholesterol efflux transporter, ABCG5G8. So that works in harmony with the NCP1L1. And then if the cholesterol, before it goes in a chylomicron, it has to be esterified by an enzyme called ACAT. And, so that's another layer of complexity. And then does it go in the chylomicron? Does it go on the surface or in the core? And then the last way the intestine gets rid of cholesterol, it can efflux it out to HDL particles. So HDLs are a way to get cholesterol absorbed. Now, each of those steps, as you can imagine, if we go through them like we did on atherogenesis in the arterial wall, it's going to get ugly. So if you want a simple answer, in general, the amount of cholesterol you eat has nothing to do with your ApoB level in the system, and certainly nothing to do with coronary outcomes, with one exception. If you happen to be a hyperabsorber of cholesterol because you got screwed up genes for Niemann-Pick C1-like 1 or ABCG5G8, then more dietary cholesterol will be absorbed than ordinarily would. So if I knew you were a hyperabsorber of cholesterol, and there are blood tests that easily show that to me, I would tell you reduce your cholesterol in the diet. But if you don't have that genetic disturbance, I would tell you to enjoy your eggs. And it would be the same thing with phytosterols. If you're a hyperabsorber, you avoid phytosterol supplements like the plague, because then you're absorbing a sterol that the human body never wants to see, phytosterols. So it's a really cool topic. I love it, having written books about it and studied it for so long.
So is high HDL given that kind of that back door into HDL, is that a potential sign that you might be a
poor
hyperabsorber?
man's marker of hyperabsorption of cholesterol. Now, most people who have high HDL cholesterol are not overabsorbers of cholesterol. But if you came to me and all I had was a lipid profile and I saw LDL cholesterol is high, but HDL cholesterol is also high, at least I ought to be thinking, does this person, are they a hyperabsorber of cholesterol? Because if I knew that with more certainty, the drug of choice for them would be ezetimibe, a cholesterol absorption blocker, not a statin, which has, can worsen absorption of cholesterol. It certainly doesn't cure it. So I think a high HDL cholesterol should suggest that to you, but then you've got to do the more definitive test. And look, if you're a hyperabsorber and your ApoB is normal, who cares? About 20% would have levels of the absorption cholesterols that would be in the top 20th percentile of the population cut points. And you could then do genetic studies. Is it an Niemann-Pick problem? Is it an ABC G5-G8 problem? Sometimes you find nothing, but they're a hyperabsorber. And it's an intricate process. There's other things at play also, including what I just mentioned, esterification of cholesterol in the gut and incorporation into ApoB48 or through an ABCA1 efflux transporter, or the intestine has the G5-G8 that evicts cholesterol. So there's so many variables. But if I measured absorption markers and they're high, you're a hyperabsorber. And if your ApoB is high, the logical way to reduce ApoB there, if you want to go down the monotherapy route, is ezetimibe. Block the absorption of cholesterol. There's not much you can do dietary-wise to block absorption outside of what you just suggested: fiber, lactobacilli, yogurt.
So on the individual level then, to answer that question, it's really, it depends on your genes, and you could probably run a little mini experiment on yourself and see how do you respond to a food like eggs, for example.
Well, yeah, for people who can't afford the test because there are more expensive tests that check absorption, fine, take ezetimibe. If it didn't work, you're not a hyperabsorber. If it works spectacularly, case closed.
One more question on HDL there. If one of the primary purposes of HDL is to kind of get excess cholesterol from cells or tissues and sort of hand it to LDL, why are we seeing HDL pick up some cholesterol from the enterocytes, and why isn't the body just pushing that cholesterol back out through the G5-G8 receptor and excreting it?
Well, it would be if that person had hypercholesterolemia. Those nuclear transcription factors in the intestine that regulate expression of ABCA1, ABCG5-G8, being the LXR especially, would downregulate the ABCA1, and that person would stop. If that person has too much cholesterol in their system, they would stop effluxing cholesterol from the enterocyte to the HDL, and yet they would force it out to G5-G8 to the gut lumen. So again, it's the nuclear transcription factors that sense the cellular milieu, and they tell the genes what to do. So we do have defenses built in against that. And the other thing is, no matter what your HDL-C is, low or high, other than a vague suggestion, and maybe, you can't bet anything on an HDL cholesterol level. It's just not a helpful lab metric.
And lab metrics will be something that we come back to in the next conversation.
Yeah, I hope we do, because that's going to do the most good to most people, for them to better understand what their everyday tests are and to know when their doctor is giving them a line of bull or not.
Mm-hmm. And we'll make sure we come back to hyperabsorber and what those exact blood tests are that people can look at that want to. Tom, this has been a masterclass. Honestly, I'm so grateful for your work, the attention to detail, the patience, the passion, the clear passion that you have for this. It makes it really enjoyable to study. Was there anything that you feel like we missed in this part of the conversation?
Oh, there's always more you miss, but we've given them a lot of good facts. Look, anybody listening to this, if you want good healthcare, you got to be your own advocate. So you listen to experts. If Simon brought him on, he's not going into the phone book to figure out who to interview. He knows who the more trustworthy, respected people in the field are. So the fact that he dragged me into this podcast, I must have something on my resume that gives me some credibility. But there's a lot of complexities we talked about here. And look, I'm 77 now. It took me 30, 40 years to know all this stuff. And as you learn, half of the stuff you learn, you're going to have to forget because it's wrong and you learn new stuff. So don't think you're going to master lipidology overnight. But some of these concepts, if you really think about it, and look, even me babbling at a high level, Simon summarized everything I said pretty easily. Now, he does a lot of interviews. He's a smart guy too. But all of this is readily available if you follow the right people. And as he mentioned, I've got a Twitter presence. Follow me, and there'll be stuff you won't know what I'm talking about, but I put stuff for everybody there, and some of it you're going to say, I think I understand this. I'm at Dr. Lipid, by the way, on Twitter.
I think that's the first step. That's first base. Everyone needs to follow at Dr. Lipid.
Yeah, it's self-study. We all have to be better students than we are, and that's the only way to master anything. But part of being smart is knowing, in today's world where the internet, for every Tom Dayspring, there's 3 bizarros out there. So be careful.
Mm-hmm. It's the wild, wild west. Well, thank you. Thank you again, Tom. I think you mentioned before this podcast would not have happened if it wasn't for cholesterol. So maybe we can say this podcast is proudly supported to you today by cholesterol. I look forward to the upcoming conversations that we have on measuring heart disease risk and then the interventions that
thank God for cholesterol. No life without it. Yep.
That's right. Thanks, Tom. There we go, friends. Thank you for showing up and the effort you're making to take better control of your health. I look forward to hanging out with you again next week for another episode.